Okay, part 2. Sorry about that. So, just looking at our vision or hearing alterations, anyone of any race, ethnicity, creed, socioeconomic status can be impacted by vision or hearing alterations. So, from the norm, um, I don't receive messages in the same way if I have vision or hearing issues, and I also can't perceive how you're saying things to me if I have vision or hearing issues because I don't pick up the entire message. Remember, as human beings, we perceive everything in one place, space, and time. So, not seeing what you're saying or not understanding how you said something based upon a visual image of your face, especially someone as animated like myself. I might make a frown face, but I'm actually trying to convey a joke or something like that. We just need to be mindful in healthcare that our face matches our expression matches the words that we're trying to convey to a client that has vision or hearing issues. Okay. An acute loss. You are blind overnight. You lose your hearing overnight. You lose sensation overnight. I'm angry when that happens. I'm disoriented when that happens. Okay. And that's something else that we would want to address. But if you're just talking about the natural progression of age in terms of growth and development, the older you get, there is an opportunity. You're at higher risk for a sensory deficit. So when we think about our nursing diagnoses, disturbed sensory perception, either visual or auditory. And when we're talking about it or when we're discussing it with our colleagues or conveying information in the healthcare arena, we will want to be able to describe cause or etiology. Why is there a visual disturbance? Why is there an auditory disturbance? And then the signs and symptoms associated with that. That's directly related to, as evidenced by, you have a client who tells you the things that they're experiencing, and then we use the different tools and techniques of assessment that we talked about earlier in lecture, your Snellen chart, red reflex, let's think about hearing, your Weber, your Rhine, whispering, cardinal fields of gaze, whatever that is, we will be able to produce signs and symptoms that are objective to support our diagnosis. A risk for injury. If you cannot see, you cannot hear, you don't perceive the world in the same way neurologically as if you have vertigo or Meniere's disease or labyrinthitis, you can hurt yourself. Okay. Risk for social isolation. There's that acute loss of the sense versus the gradual loss. But either way, there is a possibility that person wants to recoil from the world. And then powerlessness. I can't do anything about the fact that I am losing or have lost one of my senses, especially initially. So working with the client as they are processing through the loss, grieving the loss, and accepting the change in their body. So for our interventions, what are we going to do to impact the quality of life of our client? Our care is patient-centered, so it's about them. Once we find out the information via assessment, subjectively, they're going to tell us what's going on. We're going to observe and we're going to assess, and we're going to put together a plan of care for our client. It could be that they need sensory aid or assistive devices. If they are, for hearing in particular, what if they have wax in their ears? So appropriate cleaning of the ear, no Q-tips and things of that nature that can cause wax to be compounded down, pressed down near their tympanic membrane. Promoting the use of other senses. If hearing is an issue, we may be talking about reading lips or touching things to understand where we are in space and time. Making sure our clients are safe. And for us as healthcare providers, communicating, like I said, effectively earlier. We're not yelling and screaming at a client. We're right in front of them. We do not startle them. We make our presence known in a way that makes sense to the client. We're speaking reasonably and clearly to every client that we have. And always eliminating that background noise to support them to understand what's going on in space and time right now. Some of this I just talked about. We know that there's a hearing issue, speak to that better ear. No short phrases because they might not pick up what you said. Watch for nonverbals. If the client is grimacing as if they don't understand you, just backtrack a little bit and always make sure that you are patient with your client. And for hearing in particular, there's different types of hearing aids and they're all in front of you on this slide. Please make sure that you understand that hearing aids are expensive and everyone does not have the ability to replace and replace and replace. So we're always going to make sure that our client is knowledgeable about where their hearing aid or device is, that it doesn't get damaged through showering or hygiene activities. So they should remove it, always making sure it's in a storage container if it's not in use. Avoiding alcohol and harsh cleansers on the hearing aid, extreme heat or cold. These are very sensitive devices. Removing batteries to extend the life as appropriate, but more important than anything, follow your manufacturer's instructions related to care of your client's device and the care of their own device. If you know how to care for it, you read the manufacturer's instructions, that's our patient teaching associated with our client. So to help minimize the risk associated with sensory deficits, we should do what we can for our clients in terms of supporting them in regular health exams and screenings, detection activities. So regular eye exams through their primary healthcare provider, hearing exams if necessary, related to any concerns they have for loss of hearing or not picking up sounds in the same way. Immunizations to impact any diseases that may be not ototoxic, but any diseases that could impact the ability of vibration to translate or transfer from the external world down the auditory canal into the inner ear and up to the brain. No sharp objects, cleaning ears with bobby pins and pen tips. Equipment to protect the eyes and the ears as appropriate for work. So goggles, earplugs, sunglasses, or headphones like noise canceling ear protectors. If they need the support of a sensory aid, a cane, or any device magnifying, things that magnify and what have you, they should have that. And also, we should be supporting our clients to make people aware of whatever deficits they have related to their sensory system so that people can respond appropriately to the client. All right. If they wear glasses, we should be supporting them in wearing that. Okay. And then always remember that for our hygiene, for our own vision, make sure that you are looking away from screens and computers at least every 20 minutes to give your eyes a rest. Okay. Look away. 20 minutes is the goal. Look at it and look away. Okay. All right. For those who are visually impaired or blind, we need to make sure that these individuals know that we are here or coming into their space. Think about for our macular degeneration. For macular degeneration, where is the loss? The loss is in central vision. So we need to make our clients aware that we are coming in and through. The central vision is the issue. So that means we're going to come over and around at the side, and we're going to help them by placing things in areas that make sense. Understanding that there's something that's right in front of them. They may be challenged by that. And they can also work with that Amsler grid as it refers to in your text to see if there's changes that are ongoing in ways that make sense. And that's by your physician or healthcare practitioner's order. In terms of lighting, we may need to raise the lighting or modulate the lighting as appropriate for the client. We still want them to be independent. So if there's a visual issue, making sure that if we need to place things a certain way, that is how they are placed, and that people don't come and move and jostle about the equipment or supplies that this client needs to remain or maintain their independence. Okay. That was macular degeneration. Glaucoma, where peripheral vision is the issue. For glaucoma, that means we need to come in front of you. We need to come in front of you. Okay. So for macular degeneration, central vision is the issue. For glaucoma, peripheral vision is the issue. So safety, driving, do our teaching for that, and also our placement related to someone who has glaucoma. And if they have a cataracts, they have a generalized blurriness of vision. So we need to be mindful of the blurriness related to safety, them going up and down steps, moving through space and time and buildings and things of that nature. Always ask permission to help, and make sure that if we're placing our hands on the client, we ask for permission to guide and assist them through to another location. Remember, risk of injury is what we're talking about. If you have a client that falls, there's that neurological check that we've discussed earlier in lecture. We're looking for level of consciousness. Are they awake, alert, and oriented to what person, place, and time? Pupil checks via your perla. The pupils should be equal, round, and reactive to light and accommodation. Remember that consensual response. Vital signs to see if the brain is stabilizing the inner workings of the body, and if they can move their upper and lower extremities, arms and legs, with a strength that you would expect of a person of their growth and development. So I think that's it, everybody. Happy studying, happy weekend, and I will see some of you on Monday clinical and all of you on Wednesday for lecture.